I just welcome everybody to the webinar. It's being presented by the Health Services Research Association of Australia and New Zealand, and we're a member-based organisation which aims to provide networking, education and training for health service researchers and to build capacity in the field. We try and run one or two of these webinars monthly, and they're open to members and non-members, but we do encourage participants to go to our website and have a look at our services and our membership options. Our main activity for the association is our biennial Health Research Conference, and our next conference is being held on the Gold Coast in November 2017, and we're just about to launch the website for that event, so there'll be a link to that from the HSR website, so keep an eye on that. We also run annual awards and prizes, and the nominations for those are open and close at the end of July. And we have a mentoring scheme for emerging researchers, and we maintain a regular news bulletin of HSR news and comment and events and career opportunities. And if you go onto our website again, you can sign up for those newsletters. And a couple of housekeeping issues. You probably picked up that you can hear and see everything that we're doing, but we can't hear or see you. But you can make comments and ask questions by using the buttons that you'll see at the bottom of your screen. We're not sure that we'll get to all of those questions, as we had questions sent in advance, but we'll have a look at those afterwards if we aren't able to answer them. And the panel's being recorded, so we'll make that available on our website and send you a link in a couple of days. Okay, and I'll pass over to Suzanne Robinson, who's chairing the panel. Suzanne is an associate professor and theme leader for health systems and health economics at Curtin University, and she's worked with a number of Australian and UK organisations around commissioning and procurement of health and social services. So I'll switch my mic off and pass over to Suzanne.
Thanks, Sarah. That's great. Can I just check that we've still got Helen on the panel? We seem to have lost her from there.
Do seem to have lost her. I'll check what's going on. Okay.
We'll just continue, and hopefully she'll be there. So thanks, everyone. It's great to have so many people interested and able to join us today. So this is our 8th webinar that we've held this year, and we're excited to have our expert lineup. The focus of the session is on commissioning through the primary health networks, and we're interested in how the primary health networks are currently going in terms of the commissioning and things for the future. So there's 31 PHNs across Australia, and they're just approaching their first birthday. So they're 1 year old now on the 1st of July. So it's a happy birthday at the end of next week. So today's seminar is slightly different if people have joined previous ones, in that we've got no formal presentations. So instead, we're going to look to the panel to answer a series of questions. So on the panel then, we have Learne, Associate Professor Learne Durrington, CEO of WA Primary Health Alliance. The Alliance are responsible for the 3 PHNs across WA. Learne's been working in the primary health space for a number of years and was previously the CEO of one of the WA Medicare locals. Over, if we cross the Nullarbor then, so that's Learne and I should say are sat in the Waffer offices in WA, and if we cross over the Nullarbor, we've got Jason Trethowan, who's CEO of Western Victoria. Again, Jason's been working in the primary healthcare space for a number of years, and he was the previous CEO of the Barwon Medicare local. So it's great to have both Learne and Jason take time out today to talk with us. And then carrying on staying in Melbourne, we've got Associate Professor Helen Dickinson from University of Melbourne, School of Social and Political Sciences. Helen, a friend and colleague of mine, is an expert in commissioning in public services. She's partnership working, and she's been involved in research and consultancy and capacity building exercises with PHNs and also with commissioning organisations in New Zealand and in the UK. So we've got quite a lot of brain power on the panel today, and I'm going to see how deep I can dig to get some answers to the commissioning puzzle. So as I said, I've got a series of questions. I'm going to open in a second by throwing those out to the panellists, and we will try and capture questions from yourselves if at all we get time, but hopefully we might have some time to respond afterwards to questions of interest. So apologies if we don't get to your specific question, but let's make a start. Okay then, you all ready, panellists? Good. Nods from over there. We've got Helen back, that's great. Okay then, so from different perspectives, I'll start with Leanne, she's in the room here with me. From your perspective, Leanne, how do you think that commissioning is being translated into the Australian context, and particularly the WA context?
Look, there's no doubt that the notion of commissioning is new, and many organisations that we may partner with, or indeed stakeholders, would say they do commissioning. I'm not sure that commissioning, as I understand it, has actually been implemented in Australia previously. And so I'll be interested to hear from Jason, but I know that one of our challenges in building our commissioning infrastructure and resources, and when I say that I mean the clinical commissioning committees and community engagement committees, that in itself is a process to equip the members of those committees to understand what is commissioning, notwithstanding to start to bed in a process internally that works, as well as the key stakeholders. They may be service providers, but they also may be consumers of services.
Okay, so thank you. Jason, can I come over to you to see what your perspective would be in terms of where commissioning's got to in Australia and how that's translating?
Sure. Look, I think first of all, the commissioning context that we often look towards for some guidance has been the UK more so than any other country. But as time goes on, I'm finding the guidance from the UK less and less helpful. And the basis for that is that you build a reasonable amount of intelligence in your organisation about good process, a cycle of iterative improvement, the whole, whether you've got a 5-step or a 4-step process. But the challenge, and indeed always opportunity, is the diverse range of providers, particularly in the Australian context. Is healthcare is largely provided by small private businesses or non-government organisations who are at the same time dealing with a whole range of reforms from home and community care, the NDIS, etc., etc. So the context for us now in Australia and in our own individual PHNs is about that stakeholder engagement for purpose in the context of commissioning, not just for the purpose of delivering programs that perhaps Medicare Locals and other organisations before that have delivered. So I find the challenge that we have to adjust here in Australia is largely around the multifaceted stakeholder environment that you're dealing with, whether it be the GP as the referrer to a commissioned service, or whether it be a small, private, solo psychologist operating in a remote community who has to somehow maintain an understanding of what the PHN is on about and when do they get to contribute, and what their fear is in the whole process around change.
Thanks, Jason. That's great. Helen, then coming over to Helen. Just thinking, just what you're hearing from the two CEOs here and your experience of working in commission internationally. Do you see a difference then, as Jason commented, in terms of the usefulness necessarily of bringing over things from UK, or do you see it's different, similar to other settings? Have we lost Helen? Looks like it will just continue. It looks like we've lost Helen.
I wouldn't mind just
adding to that.
Because building on Jason's comments, I think it is true to say that we probably took a lot of guiding principles from the UK experience, but particularising those to our health system is both the challenge but the benefit. And while there's 31 PHNs, sharing that knowledge I think is going to be helpful to have a process that actually does fit for our environment.
And when you talk about the environment, I'll put this out to both of you, but when you talk about the environments, that's obviously different than the UK. Are you feeling it's even more local? So it's not just a different environment, you've got 3 PHNs here. So do you feel there's a difference across the PHNs, or are you trying to standardise that to have one standard approach that fits all the PHNs across Australia?
We're probably positioned a little differently. We are doing very local, what I would call in-time commissioning in country WA, which is quite diverse in terms of the regions in country WA. But in the metropolitan PHNs, it's not as local. So it's sort of interesting to see how the metropolitan environment is evolving compared to the country. I'm not sure, Jason, if your experience is different between settings.
I think you've got the ultimate experience because you're experiencing a whole state from the metropolitan to the serious remote areas. So I guess, and we may come to this later on, but when it comes to that dreaded word of decommissioning or disinvestment, I think that's where where things will be felt more should that occur in more rural settings than what they would in, say, a more of a condensed provider land being in a more urban setting. So I think there are various challenges associated with the rural, the remote, and of course the metropolitan, and sense of community. Health is a very emotive topic, and it's not just health; it's health and social care, and how you plan appropriately and then allocate resources that will actually lead to some tangible difference as a part of your commissioning cycle is one where we'll look back in a couple of years to see how we've gone.
Excellent, thanks. Helen, welcome back. I can see you back on the screen. So the question we had, and we've just been discussing, was around how helpful the UK sort of policies and procedures have been early doors, but how the PHNs are trying to localise and really develop their own sort of way of working. From your experience internationally, do you see a big difference in Australia to international contexts?
For me, one of the major differences is the organisations have quite different levers at their disposal and are sized very differently. So if you think of the UK example around primary care trusts and their role around commissioning, they commissioned a whole series of geographically based resources. They contracted GPs for their services, they contracted with hospital, as well as an array of other community and primary care services. So they had a macro view over a geographical area, rather than having responsibility for a few kind of aspects of services. So if you think of a big driver of commissioning being about having some sort of meso-level view of the health system across an area, PCTs had quite a different role to that of PHN. So I think we've got to be careful when we draw lessons across from that, because PHNs have fewer levers, I think, than some of their international counterparts perhaps had. And also they're resourced differently in terms of the size of the organisations and the staff that they have. One thing the international literature says is that commissioning is an incredibly resource-intensive activity. It takes a lot of management time and attention to do that work. And PHNs aren't resourced in the same sort of way to be able to do some of that sort of activity. So I think it's questionable. So there need to be asked questions about, well, what in the international literature can we read across that fits with the remit of PHNs, and what falls outside of that?
Okay, thank you, that's great. So just changing gear a little bit and thinking, we talked about you being 12 months old next week, 1st of July. In terms of commissioning, what would you say? And I'll start with you, Jason. So what do you think you've achieved in terms of commissioning? And one question I hear a lot is, well, what service have they actually commissioned? They're 12 months in, and what have they actually commissioned?
Well, I guess the first case, going back 13 months ago, was the principle of do no harm. And we were not in a rush to fail. By that I mean, to be disruptive, to say, well, I'm now the commissioner, I'll now hold lots of dollars and I'm going to disrupt the system, wasn't a smart move, particularly as these organisations are very new. And we were building our, not just our internal organisational structures and all the boring stuff around setting up a company, but also learning. And so therefore, what have we commissioned largely has been what was commissioned before us. And I guess as we now move into, if you see year one as organisational setup, and I know that sounds dry, but unless you get the foundations right, well, then your future success will be limited by taking shortcuts in the first year. So I think all of us will have done that and laid the foundations. Now as we're moving to year two of the PHN, it is about, this is what we're now focused on, the business that we're here for, and that is around, we've all developed up our own primary healthcare needs assessments. We've got population health views of our regions, and now we're looking at model development, particularly in the area. I know we've got lots of different streams, but particularly I think our biggest challenge is in the area of mental health. So I would think that question is best asked in 12 months or in 6 months about what have we commissioned, and indeed how are we evaluating performance and in that new role. So at the moment, I think it's largely been a contract relationship as opposed to a commissioned relationship, and that's what will be different certainly in the next year.
Thanks, Jason. Leanne, would you like to comment?
Look, I can only build on what Jason has said because we are in a similar position. We coined the phrase commissioning light, for this last financial year, and we did that quite purposefully because we knew that we were only using certain elements of a commissioning cycle, not the full cycle. And I don't think any of us could underplay the concurrent change management activity that we've needed to do alongside of building a commissioning approach. So, I would say we haven't commissioned anything. I think we've started the foundations.
Excellent, thanks. So, Helen, would you like to come in on that in terms of just that sort of academic or evidence-based? Would we expect the PHNs then to have done extensive commissioning 12 months in?
I think given the variety of different things that PHNs have had to do, getting established, sorting out different committees and going through the processes that they have with the resources that they have, I think PHNs have made really good progress in that sense, and as you say, no, we might not expect to have seen huge amounts of things commissioned at this point as these very young organisations become established, start to understand what their role is within the context of their localities, what their commissioning framework and practices will be, and have had to respond to kind of shifts around the policy context and different pots of money and different services coming into that picture as well. So I would agree that the PHNs that I've been working with have made extraordinary progress over the first 12 months, and many of the kind of outcomes and activities that we see associated with commissioning tend to be of a longer term or a longer trajectory anyway. So I don't think we could expect to see a whole series of different immediate impacts. I think that might be unrealistic.
Yeah, okay, thanks. So what we're saying is we've made good progress generally, but we wouldn't be expecting necessarily to see major commissioning. And as Jason pointed out, I mean, part of your remit was around trying to keep consistent services available for patients who might need them. Okay, so one of the other questions or themes of questions that's come through has been around sort of the design, and one of the questions was around undertaking co-design. So has there been any work done in co-design? And then it linked on to say, if there has been, how does that then work when you go on to open tender? So I don't know, I should start with you, Leanne, as you look eager to answer that.
Well, I'm only eager to answer it because I left a workshop earlier this morning, which was around one of the programs that PHNs are required to administer. And it was lowercase c, but co-design with both consumers, current service providers, and providers that would like to be a provider. And it was a workshop of that group to assist us shape up the sort of potential scope, as well as the potential outcome measures for that program. And we're going to run a couple more of those in rural WA as well. So I think for us, we've quite purposefully built in co-design mechanisms, and we've also will seek to build in, once we go to the market, opportunities for that notion of the competitive dialogue, where you work with potential, the tenderers, for want of a better term, around helping them articulate their model. Now, I guess just to very briefly, co-design is critically important from our perspective, because we want to ensure that any programs and services leverage other resources that fit neatly around more coordinated care as they're delivered.
Okay, thank you. Jason, would you like to come in on that one, which is around the co-design, and also then how you then follow that up by open tender if people have been involved in the co-design?
Sure. So firstly, on the co-design, I think it happens at 3 levels. Particularly the first one as the other main commissioner, or the dominant commissioner in state governments and jurisdictional areas are the state government themselves. And so I think certainly a lot of work that we've been doing in Victoria is to have a Victorian Primary Health Network Alliance, which is 6 of us getting together, learning from each other, but also having a single dialogue with the state government, and particularly in the areas where there are opportunities for alignment of implementation of new policy directions, such as mental health, where the state have announced lots of new money and funded programs around suicide prevention as an example, and then how would they work with primary health networks. And I think our collective view is that we should be condemned for coming out to regions with duplicate structures and duplicate ideas, and hence that addresses that word leverage, leveraging off what the state funds. Then, of course, you've got the place-based approach around the various providers and health and community service providers, which can participate in that competitive dialogue and around the service modelling that you would eventually go to market to commission. And don't forget too that the leveraging off say even just in a general practice and inside there, which is why we do practice support, so that they can actually look at ways to possibly look at new ways of doing chronic disease management in the context of a healthcare home. And so state government, place-based approach at a regional level, and then a practice. When it does come to the procurement phase, obviously part of our role then is to ensure that we haven't left providers behind who don't see themselves as capable of filling out tender responses in order to receive future funding for commissioned services. So I think that our approach will be, it'll unfold, but around supporting independent of the PHN, but mainly funded by the PHN, would be to support providers in the area of alliances and how do NGOs and how do health services and how do private practices come together in order to leverage off what's already in existence, but actually have a structure in place that actually makes it smooth for the PHN to interface with, but one that actually makes sense at a local level.
Thanks, Jason. That's great. Helen, have you got anything to add to that?
I guess I think the points being made about co-design are absolutely right. I guess on the competitive kind of dialogue working with providers front, I guess one thing we found in English experience around some of this is, there's a lot of procurement regulation there, particularly linked to the EU, maybe not for much longer. We'll find out later today whether that will be or not. But what you tended to find is people worried about this, worried about these processes, and understood that there were particular constraints on their ability to do things. Although often the kind of rules that were used, the kind of received wisdom about these, were actually slightly different to what was legally possible. And so I think a really important thing that PHNs will have to get their heads around in terms of some of this is, what can you do around procurement? What's acceptable in terms of engaging with providers, and what can't you do around this sort of stuff? And as I say, often the kind of the received wisdom and the practice in use is actually a bit different sometimes to procurement law, as people get quite risk averse and worry about overstepping marks in these processes.
Okay, thank you. Just on the provider side, I wonder, and I'll go to you, Learne, at this point. How skilled do you think the providers are at this stage in terms of being able to respond to tenders that you might, or calls that you might put out?
I think there's a high degree of variation, and Jason mentioned, those very small providers who may not have the internal capability to respond to tenders, or indeed, even if you think of a general practice who might like to do something or express interest. So we're very cognizant of the sensitivities in localities and precincts, and conversely don't want to create a market that takes away from the social capital, particularly in rural and remote communities. So while there is a capability and a topic, I think, for a number of providers, I also think there are local sensitivities around how you garner the actual providers to express interest and engage in a new way of working. So my sense is not only trying to build internal capability on commissioning, we are also working with the provider sector on building capability.
That's great, thanks. Jason, would that be similar for you? I just wondered if you've got any examples of any activities you might be doing on the provider side to build that capacity.
It's still early days, really, in terms of what we've done. Apart from, I've got to say our capacity building is as much about our organisation understanding the role of commissioning and what everyone plays. And I think we over talk the commissioning of services or health services as the be-all and end-all, but in fact, our commissioning opportunity is more in that whole service coordination, service integration, to building health system literacy amongst healthcare providers. Maybe it's commissioning partnerships between providers that are already in place as opposed to commissioning another service. So I think the appetite amongst our providers is that they express more frustration in the way in which they communicate or don't. IT comes in a lot. How well My Health Record will address some things, but ultimately we want clinicians informed about the decisions that they're making at the point of care, and that's not going to be addressed by simply putting another nurse in front of patients. It's going to be looking at systems issues and a quality and safety component around how to best assess, how to best manage. That's why we do CPD for healthcare professionals, because we have a quality agenda as well. So I just wanted to reiterate that point around the commissioning role of PHNs is significantly in the favour of systems development and improvement, as opposed to, at this stage, with the current funding envelope, than just saying how big a difference we'll make because we've got X millions of dollars for commissioning of health services.
Brilliant, thank you. Just taking that point a little bit farther around the system, and I'll just go to Helen for a second if I can. There's lots of discussion I hear about what PHNs can do for the health system. So there's a lot about what you can do from the PHN perspective. But Helen, I'd quite like your view of what you think other organisations and who these other organisations might be, and what difference they can make to commissioning and supporting the PHNs. So just, you understand where I'm coming from. So that whole point around, often it's like, well, what have the PHNs done? What can they offer? Well, from a systems perspective, who are the other players and what do they need to do to support the commissioning game?
Yeah, I think this is a really important point, and it links to the previous one as well in some ways. A lot of, so 12 months ago, a lot of the work that I was doing, a lot of the requests that I got was from PHN saying, can you help us understand what commissioning is and how we apply it within our context. So for the last kind of 3 or 4 months, increasingly it's been providers, as PHNs get to grips with those roles, providers, particularly around the mental health space, saying, we don't really understand what commissioning is or the role that we play in this or how we plug into this sort of process. So I think part of that, I mean, Learne, you sort of spoke about Jason spoke about the capacity building issues around that. I think some of that is just about understanding the process and understanding as a provider the points at which you can play into that and you can help influence that process. I mean, PHNs operate within a relatively strict, in some senses, framework around what they can support and what activities they can encourage. And so some providers, particularly in the mental health space, who I've been speaking to, have worried about the fact that particular kind of psychosocial interventions will no longer be funded, but they may be able to get those services funded under kind of a different banner. And see this as a kind of a part of a game playing. But I would say if you're a provider who wants to work with a commissioner, understanding the context of that commissioner, what they're being asked to deliver, and the sorts of terminology that they're using, and then being able to frame your services in that sense to be able to support commissioners to deliver what they've been asked to deliver will be helpful for the entire system. So I know a lot of people kind of are sat back at the moment saying, well, you know, PHNs have the money and they're leading this system and they're commissioning, so therefore we've just got to sit back and wait for them to come to us. But I think what's really important is all organisations of the system having an understanding of what commissioning actually means and the type of role that they play within that. Just because you're a provider, you don't necessarily play a passive role in this system. And, you know, Leanne and Jason have talked about that already with respect to different facets of co-design.
Thanks, Helen. Leanne, have you got a response or any other thoughts on that?
I guess, you know, well, I have a personal view, but it's sort of bedded in our PHNs. And Jason described this when he was talking about the 3 tiers of commissioning. I think we are clearly moving away from dollars funding something as being the answer. This is about integrating and maximising resources, whether they be financial or other, in the system to ensure that patients get better care. And so I think the richness is in that, and what we use commissioning for funding should actually be a leverage rather than the answer in and of itself. And I think that's the change for the sector, who've seen themselves often as a provider of something. And, even listening to Jason, it's the same echo for us. You see that in the fuller ecosystem with an eye on the patient or the consumer who's going to receive the service, rather than we're funding another widget in another spot. So I think the provider system is a partner to this as much as state government or indeed other commissioners like the Mental Health Commission.
And do you think the providers understand that at this point, or some?
No, I think some are beginning to. To be fair, I think there are some who do actually understand that, but that is, in my sense, a much greater sophistication in the thinking. And also it does reflect whether the organisation feels quite vulnerable around its funding, and therefore it's all about they need the funding to survive. So I think it depends on the organisation.
Okay. Jason, have you got any other thoughts on that point?
No, look, if you go back to one of the original points we were discussing around service continuity in year one for the flexible funding, whether it be mental health or chronic disease management, more broadly in our, say, rural health communities, that there was a rollover of existing arrangements in order to do no harm. But it's, our providers know, for instance, when that opportunity will arise for that service redesign to meet those needs identified in our primary healthcare needs assessment. So there are funded agencies who are already, before we've even asked them to do anything, they're actually thinking about how they position themselves and their communities to ensure that they are ready for the commissioning environment. And there's a number of that are doing that, and they'll no doubt be really ready, have a position before a tender even comes out, or even before they're invited to do workshops. There'll be others who may be either thinking it's going to roll over to be the same. They're busy in every other day life. So I think it is heavily, it's a disparate environment that we work within. But I do like those proactive ones, even if they are a current funded agency or not. There'll be those who are looking at it not necessarily from how can I get lots of dollars, but how can I leverage off other parts of the system so I can play a greater role and expand my business perhaps as a result of that.
Excellent, thank you. Okay, well, we'll shift a little bit in terms of the focus. One of the particular set of questions came around from general practice. So I'll start over with you, Jason. And one of the questions was, so PHNs will be commissioning services from general practice, which we've sort of mentioned. And the question really links to what types of services will they be likely to seek from general practice? And I don't know if you've got any thoughts or response for that one.
So I guess maybe this is a relationship between a PHN and a general practice, no matter how big or small. And I'll go back to the leveraging discussion around, as we've had this conversation, there's been thousands of patients being seen around Australia. So the world goes on despite the PHN doing something constructive in the last hour just through this discussion. So what they will be, I think, looking for is relevance. They want to be, and certainly we see general practice as central to the primary healthcare system and its various interface to the broader health and community services organisations that they and their patients engage with on a regular basis. I'm not so sure right now about the role that general practice plays in the context of being a recipient of funds for the delivery of health services until we actually run that process through to see how commission ready they are or what their appetite is to participate in this environment. But I do know one thing, and that is that we will lose general practice if we commission services that just create another silo for them to find out who they are, where they are, and how do I refer to them. So that's why why we have primary care consultants who work with general practice on chronic disease management systems, our digital health team who support the uptake of secure messaging and the My Health record, CPD for clinical practice, health pathways as an example of a care pathway system to support the GP and general practice when they've got patients in front of them. I think what's missing, and maybe this is where the healthcare home will come in, is around the marketplace for GPs in terms of who they can refer their patients to. And certainly in rural areas and some of the growth corridors of urban communities, you just don't have the diabetes educators or the dietitians or the podiatrists to refer to. So no matter how good the healthcare home is designed, a workforce is absolutely essential. And I'm looking forward to learning more about the model for the healthcare home and indeed the role of the PHN to perhaps be creating a marketplace and incentivising, because previous incentives have not worked. Rural location incentives have not worked in the past. We still have a maldistribution of workforce. We have an ageing workforce where there's an ageing community, where there's multi-morbidity and shrinking communities in population size. So there's lots of factors going against us. So I think our test will ultimately be how we commission a market in order to be responsive to the local needs of those patients, of which general practice can actually leverage off.
Thanks, Jason. That's great. Have you got any other thoughts?
Look, I just it builds on Jason's comments, but and I can just say Jason and I didn't practice this, so
I know.
but I think general practice community is not unlike other communities. It's quite disparate, and we would have practices who are change ready and would like to be a party to having involved, a party to commissioning effectively, whether it's in the patient-centred medical home and some other developments. So again, there are early adopters who see that there are significant changes in primary care ahead, and they would like to position themselves for those changes. And there are others, of course, that are just very busy practices doing their thing. So, but we do see that going forward there will be a place for general practice, and conversely, we don't see that there's a one-size-fits-all in this. It is practice-specific. It's not a program that looks exactly the same for every practice.
Yeah. Okay, thanks. Helen, have you got anything to add at this point on the general practice perspective?
Not a huge amount. I guess I'd echo what colleagues have said, and I guess one of the challenges is, I suppose, back to this issue of kind of the system is, I think a number of providers assume that PHNs have kind of quite a bit of clarity around these issues and kind of fully understand the context that they're operating in. But as we've heard from the two comments there, actually there's an awful lot that still isn't really known around what what the role of PHNs is, and how they will interface with general practice and other kind of organisations around the system. So it's it's an emergent kind of policy context, and one of the things that I've been doing a lot of, and I'm sure so have others, is kind of trying to communicate with providers and other partners. And actually, nobody has the entire picture about this. It's not that you get in the dark around some of this. Is that actually we don't quite know yet how this is going to work. And some of that is because we just don't know, and some of that is we'll need to experiment to find out what works best, and it'll be different in different areas.
I suppose what I've heard from the CEOs is that there's an appetite to engage. So that appetite, if people want to come forward, there's an appetite to engage with general practice and other people from across the system. We've got a couple of questions from the floor, so I'll read them out. I'll start with a question from Nazil, and I'll target this. It's targeted to I'll target it to everyone. I think last time one of the problems with Medicare locals were lack of clarity for PHN's performance criteria. So lack of clarity around performance criteria, particularly performance criteria around integrated physical and mental care for chronic diseases. And the question then is, do you think the PHNs are in a position to claim that this problem has been fixed?
I wouldn't
No.
say. Oh, sorry, you go, Jason.
One word answer is no.
Yeah.
Okay, thank you.
And I was about to say I don't think it's been fixed, although I would add, having been in a Medicare local for a small amount of time and now the PHN, I feel there is far more clarity, albeit the solutions will be diverse.
Yeah, and I suppose that links to maybe on from that question, well, what's different about you than a Medicare local? So, what's different about the PHNs here in WA than what might have been previous in terms of Medicare locals and what their role was?
Well, again, I would say I feel there's clarity, albeit there's still a lot of ambiguity. And as Helen said, no one has the one answer. We have to work in partnership with our colleagues, whether they're the colleges or the State Department and so forth. But I feel that we've been given headline criteria that sharpens the focus, and I think the Commonwealth have been much clearer on being a primary healthcare organisation as a commissioner and a system change agent, rather than mixing the metaphors between service delivery and the sort of system change agent.
Yep, thank you. Jason, anything to add to that, or are you?
No, I concur. I think the the sense of region is far greater in the PHN environment. And I guess I think it's fair to say that the Commonwealth are viewing PHNs in a way that they never viewed Medicare locals. And I think it's fair to say state governments are doing the same. And I know it's a slow dance at the moment with our state colleagues, but it's a very promising one, and that is that ultimate thing around co-commissioning for the purposes of getting greater bang for the buck, really, and in local communities is certainly there. So I feel that I'm working for an organisation that has clarity around its purpose. The how I get there might be similar to Learne, but what I end up doing may well be very different to what Learne's doing in WA.
And that's because you're there to be, in terms of trying to serve the local needs, which might be very different than a WA local need, which you'd expect. Sure. Have you got anything else you want to add to that? Just thinking about the Medicare locals and the difference that we're seeing in PHN world, the Medicare local world?
Maybe the only thing I'd add to what others have already talked about, I guess, is if we think of the broader kind of policy context around health, I guess, particularly if you look at some of the promises that have come out by the various political parties in the run-up to the election to come, what seems, I mean, although a lot of the promises within there seem to still be around kind of funding of hospitals and kind of committed significant amounts of money to hospitals, actually each of the parties have set out a kind of a plan around chronic disease management and strengthening of primary care. So I guess maybe one of the kind of differences, along, outside just of the kind of the function of PHNs and their difference to Medicare locals, is I think there's starting to be a broader acceptance that actually we need to do something significant around the way that we operate primary care if we are actually going to be able to grapple with complex issues around chronic disease management and health disparities. So I don't think that is unhelpful as a background context for PHNs.
Thank you. I'm going to take another question I have from Jonathan Carnan. So he's directed the CEOs, and he said, could the CEOs briefly describe the physical commissioning process? For example, does a committee define or rank needs to be addressed and then select programs that best meet each need until the budget runs out? So basically, how do you priority set and rank things in terms of, does that happen at committee level or does that happen somewhere else? Do you want to give it a go, Leanne?
Sure. It's a complex question, but sorry, I'll answer it. In our structure, our committees do determine priorities based on analysing population health data and other data sets. So what is in fact the high priority need in the particular location? So that's the first part of the priority setting with me, is from the evidence around the current supply and the health of the community, what are the priorities that emerge that also fit with the parameters in which PHN operates. In terms of what then is the service response, while the committee has a role in bringing to the table and seeking out evidence about the best interventions that might respond to the particular issue, they don't then become involved in the tender, for want of a better word, the tender process for selecting the organisation. In our organisation, our board holds the fiduciary duty, like any board does, and while a recommendation is made to our board through a tendering process, the committee does not. There may be a representative of the committee sit on the tender panel, but the committee in and of itself doesn't determine who the provider is. So it's more a prioritisation by demand, supply and population need, and then what are the evidence of interventions, for want of a better word, that may best respond to that particular issue.
Thank you. Jason, would you like to comment from a Western Victorian perspective on what you're up to?
Oh, look, it's in development, to be honest. I feel what Leanne said is where we're heading to without it being described that way, and in terms of whether it being formal in our sense. I mean, certainly there's a need for, the whole probity, which really is about a process of fairness, to ensure that we can stand up and say, yeah, we've done the right thing. It makes sense. Someone's disappointed, but they can see why we've done it that way. I think it's it's one where there will be variability around how PHNs will do this, and I guess it's an example of how individual companies, as we are, go about it. But what you cannot escape is obviously the fiduciary duty of directors of the company. They can't escape a decision because they do reserve the right to perhaps intervene if it was a rather odd recommendation for an allocation of a resource to a particular part of the community.
Thank you. Helen, have you got anything to add to that one? I don't know if you've got any perspective from the work that you've been doing.
Well, I was just going to say, I mean, as you say, the kind of current processes around this are somewhat in train, and they're developing, and we'll see them over time. In research that you and I, Suzanne, did in England a few years, looking at primary care trusts who at the time were responsible for the spend of 80% of the NHS budgets in local areas, we investigated the type of priority setting processes that those organisations had put in place. One of the big drivers of commissioning in England like that, to some extent, of the PHN story was about making priority decisions more explicit. Now, the challenge, of course, is you don't make a decision on all of your budget at the same time, and you're locked into contracts which come up at different points. And so while it'd be nice to think you would sit down with your budget and say, what's the best way we can spend this? Let's put it across this area, this area, this area. That's not quite what happens in practice. In the research that we found, although PCTs had invested quite a bit in priority processes and making them more explicit, actually the more systematic parts, like the kind of question intimates, were sat around new money rather than the core budget of the organisations. And so what you found is there were these processes for new practices and new money that would come into it, but those same priority setting processes weren't necessarily applied to the core budget. And that's, and that wasn't because for any bad reasons, but more because actually to go through your entire budget and think about allocative efficiency across the piece, particularly when you've got contracts coming up at different points and different services, is a really difficult thing to do. So, so there is an extraordinary amount of time and effort that will have to go into designing these processes to ensure that they're as fair and contestable as possible.
Thanks, Helen, that's helpful. I suppose in terms of that as well, there's something around the time it takes and whether that's cost effective to actually develop some of these very explicit processes. And I have seen some processes win awards for being wonderful, but not actually manage to implement a single decision because they've not worked very closely with the external environment. Yeah. So there's a trade-off to be had there as well, I think.
And again, remember the point I made earlier about the fact that PCTs had far greater resourcing to be able to do some of this work. And primary health networks, I understand, have been told that out of your entire budget you can spend between 6 and 7% on the actual commissioning activity, and the rest needs to go into service delivery, which means the amount of capacity and capability to be able to set up and establish this sort of process may not be there. I'm not convinced that's the right take either, because I don't think spending money on commissioning, if that's about allocative efficiency and making the system better, then if you're spending on commissioning, it doesn't mean you're not spending on clinical service delivery. So I think there's some issues there that we'll need to kind of think about and play out a bit more if PHNs are to be allowed to be able to do that sort of activity.
Thanks, Helen. That's great. Thanks. Okay, let's think about, we're 12 months in, but let's think about the next 12 months. Just like, we're really interested, Leanne, from your perspective of the PHNs here, and it may be that you take each PHN might be different. What would be the key achievements if we were sat here in 12 months and we were, so I'll give you the crystal ball gaze at the moment. So you sat here in 12 months and we're back just saying, well, what have you done in this next 12 months? What are the big ticket items for you and your 3 PHNs?
Well, there's no doubt that we do have some time frames. I just thought I'd mention that about what has to be commissioned by when. And so I guess at a crude level, meeting our contractual obligation would be a great thing. And there's no doubt that we have some great opportunities to do some integrated service design with the sector, particularly with the alcohol and other drug funding and mental health, notwithstanding many of those people have a chronic disease. So for me, I think in country locations, there's no doubt we'll see some great integration across the spectrum for certain population groups. And we are, not unlike Jason, we're very interested in how general practice emerges and also, how would you say this, starts to feel like it's engaged in a fit-for-purpose operating model for the changes in our health in our community. So that's probably too far. That's probably a bit too far out for 1 year. But for us, it is to have undertaken what we would call some rich commissioning processes that have resulted in good outcomes in and of themselves, and that the feedback from those engaged in that is a value add for them.
That's great, thank you. Jason, what about over in Western Victoria? What are the key things you would like to achieve in the next 12 months? You just need to turn your volume on, Jason. We can see you but can't hear you.
Oh, that's convenient for many people, I'm sure, but now that I'm speaking, you can hear me. I think one outcome sitting back in 12 months later will be I will be able to describe the mental health system. At the moment, I can't describe the mental health system. I can describe a series of services. I think I know where most of them are based on our service mapping. I don't really know how a GP can be fully aware right now of all the options that they have for their patients. I don't think families understand what they can do for their young one, apart from if they're lucky enough to have a headspace, not far down the road, where to go. I think it's, when I say describe the mental health system, I'm talking about describing the service system, how it relates to each other, and indeed how does the, even for the well population who are perhaps even having early warning signs of even mild to moderate mental health concerns or issues with their, working with their practitioners, how do they link the online environment, the Googling into the service system? And I think that's a huge role, because until, if someone says, we hear a lot now about we need more money for mental health. And I'm sure we do, but how do we know we really do until we know that the system is working in a more coordinated way? So I have no doubt more investment is required in that context, but we need to, at some stage, be able to just describe the system, because at the moment it's a series of services, not a system.
Excellent, thank you. Helen, what's your response in terms of what you'd like to see in 12 months?
Rather than answer the question kind of with the specifics that others have, I guess my comment would be just to ensure that commissioning is a difficult, resource-intensive, long-term set of activities, and I think experience in other places has shown that expecting things to be delivered too quickly or expecting to see a whole series of outcomes at great speed is not necessarily realistic. And I think if we're serious about going down this route, and I think we do need to be realistic around that and have some kind of patience and understanding about what we expect to see over a short term. And so it might not be that we look for, and I think Leanne and Jason have talked about this kind of huge kind of outcomes, but really robust processes and relationships start to develop that hopefully should be able to drive improvements through the health systems in years to come. So I think we've seen in other countries, England particularly, where we had kind of huge reorganisations of commissioning functions with kind of regularity as we got impatient with those, and indeed there's a suggestion that in not very long commissioning may disappear from the English healthcare context altogether as patients have been lost with that agenda. So I just think we need to be careful about what we expect to be delivered in such a short amount of time.
I suppose that links back to, if you want to see, as Jason, Leanne and yourself have mentioned, health system change, that takes time, and it takes lots of work in terms of engaging with that community and in terms of all the players in the system. So it's not going to be an overnight fix, and have to support the HNs in their role to achieve that. I've got a last question, and I think it's important to go back to patients as consumers. So I thought I'd end on the consumer question that came through from one of our audience. And it was, how does the commissioning process support engagement with consumers and carers to ensure integrated primary care?
Well, as I said, just to briefly answer that, we had a process this morning where we had consumers of the current services present in the co-design workshop, which I think is critically important. We see our role also as moving into engaging community as well as consumers. I mean, I think most people use a health service at some point, but we have worked on, in one of our foundations is community engagement and involving them in the debate about what's value for them. So again, there's a few levels in this from our perspective.
But consumer at the heart of the way they're doing
absolutely.
it. Okay, Jason, what's your work in terms of that space with the consumers? Any examples that you can give to us?
No, certainly the role of our community councils have a, part of their breadth is not just about a critique of how our organisation is going in their local area, but also how they bring a network's consumer voice to that co-design process. So, I know give you some examples. We did, like me, we put a notice in the paper and a few emails out to the community to turn up to a location for a discussion about the health system, and we got 0 attendees in a particular location. And there's any reason why, is because people are fatigued about the chat about what needs to be done. But I think when you move now into the next component of our commissioning cycle around developing the solution, if you start to meet the purpose, consumers will come. And we need our community councils to bring them, because they are the ones who are more networked locally. So I think that's a really exciting space that we're moving into, because it is a very different discussion about tell me what's wrong with the system versus what can we do to help make it a better one that the PHN is going to follow through on, in terms of either way, a commission service will be provided, but is it going to be the best one? And in order to do that, you have to have those community councils heavily involved in bringing their people along in that conversation. I think that's a 2 and 3 year project, mind you. I don't think that's anything we're going to get in the next 6 months. So we're building.
Yeah, thanks, Jason. That's great. Helen, any comments from you on the consumer engagement perspective?
Yeah, just to echo others and say it's absolutely kind of crucial to the commissioning endeavour. If you want legitimacy as an organisation, then you need to be valued by the community that you serve. So I think there is a real job for PHNs in this initial phase to really think about what the value proposition is for the locality area. One of the problems with many of the definitions that you get of commissioning is that there are kind of a list of quite abstract sorts of activities that go into that process. And I think what we need to do instead is define commissioning by, well, what's the point of it? What are you trying to do for the end user? And why should somebody care about what their local PHN is? And they'll only care about it if it does something for you. I mean, I sit on one of the community advisory councils of one of the local PHNs, and that's in Melbourne, and that's one of the messages that we've been giving to our board. And I think, as Jason said, it's a long process, and I think to do community engagement well, you need to think about it very carefully and think about what your promise is to those organisations or those individuals who engage. Too many people have been involved in a tick box kind of tokenistic exercise in the past, and I think if you do want to have that legitimacy, you need to really plan this carefully and think about how those engagement activities fit into the kind of overall governance structure of the organisation, and not, which has happened sometimes, you do the kind of engagement activities and then it kind of goes in a bottom drawer and doesn't really go any further. So I would say, carefully thinking and prioritising different groups and then putting things in place, which may take a bit of time to design, but I think that's a good thing if it's really thinking about how we do that carefully.
Thanks, Helen. So I think the message, and I think we've heard that's happening in terms of both of the PHNs around taking time to make sure you get it right is worth it, but they're already starting to engage with the community as much as possible. Okay, then, well, we're getting close to time, so I'm going to bring this session to a close. I'd first like to take the opportunity to thank all the panel members, to say thanks for being honest and open and for providing us with your time today. It's been great to speak to all three of you. Also, thanks to all our audience out there for joining us and for staying with us till the end. And thanks to Sarah Green, who organised and coordinated this session. And we're a bit like herding cats, so she's done a great job of sorting the panel out and organising all the IT and things for us. So thanks, Sarah, for that. Just to point out to people that whilst the seminars are free, we are a member organisation. So if you are interested in joining, then please visit our website. So please feel free to visit our website or contact Sarah Green for more information. Our next conference, as Sarah said, is being held in the Gold Coast at the end of 2017. So it's a nice place to visit, and it's always a great conference. And the focus of the conference will be on current and future priorities for resources in acute and primary care, in order to achieve a sustainable and functional system into the future. So again, more information on the website. So all that's left to say is enjoy the rest of the week. Thanks to all, and we look forward to engaging you in our next webinar. Thank you.
Thank you.